for asking me to talk to you today. I've been working with people with head injury for about 40 years in the NHS, and also have been involved in research and teaching about head injury at the University of Glasgow. And so there's an association that we know about between traumatic brain injury and people getting involved in the criminal justice system. And just giving you a bit of background and context here, the Scottish Cabinet Secretary for Justice instigated a report in brain injury and offending, and it was produced in 2016. And since then, there have been initiatives to develop research evidence-based services for people in Scotland. And I want to talk to you a bit about that today with an emphasis on young people. So the main things I'm going to cover is really an understanding about head injury, of how that affects the brain. And in particular, when there's damage to the brain, how that can affect emotions, thinking and behaviour, and how that might intersect with people breaking rules and getting involved with the law. And then towards the end to talk a bit about what we can do about that. And why this might be relevant to you is that head injury is very common in people involved in the criminal justice system. Some effects of head injury are known to increase the risk of offending behaviour, and it's also associated with other common issues in young people, problematic use of substances, mental health problems, and it can affect the threshold for violent behaviour. And people with a history of head injury are also at greater risk of future head injury. So maybe there's something that we can do to prevent that. There are things you can do to help, and so as I said, we'll talk about that towards the end. So if we just think a bit about the brain, how it matures, and the brain when it becomes injured, and how that affects behaviour. So there are a number of theories about criminal behaviour, and a number of the kind of social biological theories revolve around problems with self-control and people having less self-control following a brain injury. And we know that frontal areas of the brain are involved in helping us to synthesize information. So there'll be information we have from memory, from past experience, our evaluation of what's going on currently in our environment, working through problems, working out plans, and exerting control over more primitive areas of the brain, such as the amygdala. That's a more primitive area of the brain, and it develops at a younger age. So it develops more rapidly than the frontal areas of the brain, but it can't process information in very much depth. So the kind of information it's involved in would be sensory information, things we see and hear, and emotions. The frontal lobes, they continue to develop into our mid-20s. And so younger people will be more likely to be impulsive or act rashly or as an emotional response than adults would, because they don't have the same level of control that an adult would, because their frontal areas of the brain are yet to develop fully, whereas the more primitive areas of the brain are already fairly well developed. And if any of you, I'm sure some of you will be parents or will have younger siblings and so on, and you generally have noticed that young people tend to be more impulsive. So we've got here a picture of the brain. If you slice down the side of somebody's head, and the prefrontal cortex role, they are important. So they will tell you that if there are early signs that what you're doing isn't really working very well, to link it back to past experience, and it'll compare that with what you're doing now. And so it's kind of monitoring your behavior and the outcome, and allows you then to change course into a more positive or an outcome's likely to be better for you. So control your impulses and your emotions. It helps you to make judgments. It helps you to understand the reactions of other people. It helps you with thinking in an abstract way and to analyze information. It regulates your behavior and helps you to predict what's about to happen. If the brain is damaged by physical trauma, the prefrontal areas often become damaged. And this can result in severe disinhibition, or a more subtle effect where people can act rashly and basically have poor self-control. So you can get a very obvious effect. You think, actually, something's not right here. This person had a head injury. We can link these two things together. Or they can get more subtle effect where the history of head injury may not be associated with having poorer self-control. It's a bit more subtle. Now, this kind of disinhibiting effect is made worse by intoxication, effects of alcohol and drugs. Now, these effects can be greater after a brain injury, and the person who's had the injury may not be aware of that, putting them at greater risk of acting in an ill-advised way, breaking rules, being antisocial. There's some other effects of brain injury that are relevant here, but let's see, first of all, if there's evidence for association between brain injury and crime. And it's difficult to establish a clear cause and effect because people involved in the criminal justice system often have very complicated backgrounds, and we'll look at this in a bit more detail later. However, there is evidence to indicate that people with a history of head injury are more likely to be involved in the criminal justice system. Research evidence shows that offending is more likely after head injury, and there have been some birth cohort studies carried out on Scandinavian birth cohorts, so they get evidence, information from people from when they're born, and they can link that up to later history of being involved with the law. And if they look at, they find that people who have a head injury are more likely to be involved in the law, but they've also been able to look at siblings. So if you had one sibling who had a head injury and one who didn't, the one that's had the head injury is more likely to be involved in the law. And looking at siblings gives you a bit more of a control for the environment that they've both been brought up in, suggesting that head injury might be an important factor. And we've carried out quite a lot of research in Scotland, and we know that people in prison who've got a history of significant head injury, I mean by that head injury history that's likely to have had persisting effects on them. We know that they've spent more time in prison, they've had more convictions than prisoners that don't have a history of head injury. Adult men in prison with significant head injury are 5 times more likely, and women 3 times more likely to have convictions for violence than prisoners without head injury. We also carried out a census of all of the prisoners in Scotland on a particular, in prison a particular day, and we linked that up to records of being hospitalised with head injury, and found that if you the prisoners were 2 times more likely to have had a history of hospitalised head injury, and we compared them with the general population, and we matched them to the prisoner population by age and background, to try and control a bit for environmental factors. So a bit more then about head injuries in prisoners. The studies that we've done shows that most prisoners have a history of mild head injury, where there's brief or no loss of consciousness, although about a third of them, of the adults, would have had a moderate to severe head injury, where they'd been knocked out for more than 30 minutes, often with mild head injuries in addition. But what's characteristic of the prisoners is that they very often have a history of repeated head injury, where they've had many head injury over periods of years. And this can occur due to gang violence, assaults, being involved with drugs, domestic abuse. These are common causes. Domestic abuse, particularly in women. And the repeated head injury can have cumulative effects over time. And you'll be aware that's come into general consciousness in the public through sports and rugby, increasingly in football and some other sports. And you'll know that maybe in rugby, if somebody's had a knock on the head, they will take them off for a head injury assessment. They'll carry out some cognitive tasks and compare them to the performance before they played the game, and they may withdraw them from play. And they might withdraw them from play for up to about 3 weeks, and to give their brain time to recover. The issue is that if you have an injury and then you get another injury fairly soon thereafter, it will have an additive effect. And we'll talk a bit more about the nature of the injury to the brain in a minute. In Scotland, 2/3 of prisoners had histories of repeated head injuries. So the majority of prisoners had this kind of history. And despite this high occurrence, about 40% of them, despite having had all of these head injuries, had never been to hospital. So they hadn't really had advice or guidance about head injury. So a little bit now about basics about head injury and its effects. So why do I keep talking about head injury? Is it the same as traumatic brain injury? So head injury is a more cautious term. It really describes a knock to the head. And it may just be a superficial knock to the head. We've all done that at some point, banged your head on the table or done something like that. But it can extend through to really having had a significant brain injury. And it's a more cautious term, avoiding attributions and stigma. And it's quite important. You wouldn't want to start describing somebody as brain damaged when they'd had a knock on the head and the impact of it hasn't been assessed and isn't clear. So I tend more often to use the term head injury unless it's been very clear that the person's had a severe brain injury and which has been assessed. Interestingly, the International Classification of Diseases, which gives codes for all disease, uses the term head injury and has a whole range there, just as I've described, from superficial injury to serious intracranial damage. Nevertheless, head injury can result in brain injury. And traumatic brain injury is the rapid acceleration or deceleration of the brain, resulting in the development of force within your skull that will cause diffuse injury to the brain. You can also get focal injuries, such as contusion and intracranial bleeding. Contusions to the brain is really bruising and laceration. It's similar to what would happen if maybe when you're younger, you fell over, scraped your knee, and you'd have these lacerations in your knee and bruising round about it. And that's what contusions are. Intracranial hematoma is where blood vessels surrounding the brain have been damaged, have been leaking, and it causes pressure within brain. Obviously, within the brain's within the skull, so it's nowhere to expand to, and it's because of pressure and lack of blood supply to feed areas of the brain. Edema is where fluid comes out of cells and makes the brain swell, again causing pressure and damage to the brain. And there can be metabolic effects whereby the neurochemistry of the brain is affected and can be affected for quite a long time. And some of these metabolic effects can cause secondary damage to the brain. And diffuse axonal injury, I'm going to talk a bit about specifically. So I'll talk a bit about cerebral contusions and diffuse axonal injury, just briefly. So imagine you're looking down through the top of somebody's skull, and the big kind of this big hole here is called the foramen magnum, and that's where your brain stem sits, and your spinal cord goes through there down into your spine. It's the front of your brain up here, and you'll see here that there's some bony ridges here and here, whereas around the back of your brain it's relatively smooth. So if you can imagine your brain being shaken up, rapid acceleration, deceleration, it hits off the bony ridges, and you can get these focal areas of damage, this laceration, contusion of the brain, and the frontal areas of the brain are around here, which are areas we were particularly interested in that we're talking about a bit earlier. So this is a kind of diagram of a neuron, and the brain's made up of billions of neurons, and it's the cell body here. It's a long axonal tube, and electrical current passes down, which will stimulate the endpoints here, causing release of chemicals, which will either encourage another nerve cell, be attached here to another nerve cell, will encourage it to fire and send an impulse, or it will inhibit it and discourage it from firing. And so you can imagine it's connected here to lots of different cell bodies, and having these vast networks of nerves all interconnected. Now, you can imagine that if somebody's brain is being rapidly accelerated, decelerated inside the skull, it's connected, it's kind of anchored, if you like, by the brainstem. It's not just entirely free floating. And so you get these forces set up causing shearing and stretching and twisting of axons. And what this can do is it can injure them and mean that they're not functioning properly for a period of time. Or it can damage them so significantly that the axon does not recover, the cell body is damaged and dies, and the whole nerve, the whole neuron dies. It can be that a different neuron then will grow these boutons and connect and re-establish some connections. But you can, in diffuse brain injury, get large areas where there's damage, and very significant damage to lots of neurons. So diffuse axonal injury is characteristic of traumatic brain injury. It's something that isn't picked up readily in routine scans in hospital. And so it's another way in which head injury can become hidden, a significant head injury. And gives you just a bit of insight into why the brain sometimes can recover quite quickly, and why, if the cells are damaged and die, it might not recover. So just briefly, I've been talking about milder injury, more severe injury. Mild traumatic brain injury is where there might have been no loss of consciousness or loss of consciousness up to 30 minutes. And it's you also get during a period of time where there'll be post-traumatic amnesia. And this is a state of confusion and disorientation. After mild injury, it might not be terribly obvious, and it would have to be assessed. Moderate to severe injuries where loss of consciousness is for longer than 30 minutes, and post-traumatic amnesia is longer for 24 hours. They're confused, disorientated, don't know where they are, might not recognize people, not aware of the correct date and so on, disorientated. So I said we'd come back. We've talked a bit about how the brain comes damaged. So, but what are the effects of this? I said we'd talk a bit more about this, a bit more detail. And most often there are not persistent physical effects. Many of the complaints people would have are non-specific. They can arise from many causes. And there are often, though, emotional and cognitive changes that affect behavior and that can persist and that are especially relevant to offending. So we're going to look into that a bit. But here are common effects of mild head injury in red. So headache, problems with concentration and memory, dizziness, irritability, fatigue, being sensitive to light and noise, having changes in sensitivity of smell and taste, and sleep problems. And you can see these are fairly general problems, the things that you might experience if you've had a cold or flu, or if any of you have ever had a hangover, you'll be well aware of these kind of effects. And so they're not always attributed to the head injury. If someone's been out, they've got into a fight, they've been drinking, they think, oh, I don't feel great, I'll just go to bed, wake up the next morning, and say, I think I've got a bit of a hangover, whereas actually they've maybe had a head injury when they got hit in the fight. In blue, they're intolerance to alcohol and drugs, which I mentioned before. Kind of ringing in the ears, tinnitus, blurred vision, and pain. These are slightly less common. All of these problems can also happen after more severe head injury, but you can also get these other physical problems, epilepsy, poor clarity of speech, limb weakness, poor coordination, and tremor. You can get these. We need to think more about the long-term cognitive and emotional effects, though, after repeat head injury or severe injury. Because I've said it's just so common in people involved in the criminal justice system. And I mentioned poor self-control before, and I mentioned that people can be more impulsive. Their threshold for aggression and violence is lower, they're more irritable, egocentric, so really thinking about themselves and how the world's affecting them, and not so much about other folk. If they carry out an act that's antisocial, may have no concern about it at all, have no feelings of guilt or remorse whatsoever, have reduced empathy, judgment impaired, and some people may have apathy, which means they don't really get round to doing things. Now, you don't find necessarily all of these things in the same person. They may be in different degrees. Some may be more evident or more severe than others. Cognitive effects, in addition to concentration and memory that I mentioned, include this rigidity of thinking. So people persist in carrying out an action despite getting feedback that it isn't working or it's having negative outcome, but persist doing it. And may even then go and do it again on another occasion, despite having had a poor outcome. Thinking very concrete, things seeming to be black and white, so not seeing nuance, areas of grey areas and so on. Difficulty planning and not being as good at problem solving. And I mentioned that impaired self-control is a key feature in some theories of offending. And a tendency, therefore, after brain injury to act on impulse, to be aggressive, not care about the consequences for others, and the head injury affects exaggerating the effects of alcohol and drugs. What this means is that in principle, history of significant head injury is likely to increase the risk of rule breaking and offending. And these problems are often associated with other problems, other consequences. People will then react to, people around about the head injury person will react to this, and the people find that they are suffering mental health problems, anxiety, depression, and may have PTSD. So having said all that, just how common is head injury in prisoners? And synthesis of studies carried out around the world suggest that more than half of prisoners had a head injury. And we've assessed more than 500 people, interviewed individually more than 500 people, and young males in prisons in Scotland, and found in each case women, adult males and young males, in each case 80% have had a history of head injury that's likely to have had a long-term effect. Very common. We looked at disability to see if people were disabled and if that might be associated with a head injury. And we found that disability linked to head injuries often associated with mental health problems and anger control, not with physical problems, which I was kind of mentioning that earlier. And disability attributed to significant head injury was found in a third of adults, but was less common in young offenders. Now, I'm going to talk a bit about the young offenders specifically in a minute. So how do prisoners get head injuries? In the general public, the most common cause in Scotland and the UK is a fall. But in prisoners, it's assault that's the most common cause. In adults and young men, often in fights, in women, domestic abuse. But they have multiple head injuries very often, as we've said. And so they will have head injuries because of fighting, because of falls, and falls associated with intoxication. And other causes include traffic accidents and sport. Sport most often would be martial arts, falling off bicycles, that kind of thing. So I'm going to move on to talk about head injury in the context of other issues with people involved in the criminal justice system. And I call it the weave of multimorbidity. It's like a rope or a weave with various large threads in it, and one of them I think is head injury, but there are others, and they combine together to give disadvantage and risk, I think, for these people. We know that people in prison have high levels of health morbidity, particularly to do with drugs, alcohol use and mental health. And they've also often got a background of trauma and abuse. I've explained about the repeated exposure to head injury. They more often come from deprived backgrounds, very frequently have had limited attendance at school or have had special learning needs. And the strands in this weave interact with each other. And but given our focus on head injury, let's take head injuries as an example. So in our studies, more than 80% had a problem with alcohol or drug use. Mental health problems were common, especially stress-related problems, clinical anxiety and depression. Most reported a history of abuse or trauma. About a third reported a history of neurological disorders other than head injury. And 2/3 of women reported chronic health physical condition, a bit less common in adult males and much less common in young men. But if you're a prisoner in Scotland with a history of significant head injury, compared to prisoners without head injury, you're more likely to have had disrupted schooling, history of emotional trauma, mental health problems such as anxiety and depression, have drug and alcohol problems, and be at risk of head injury in the future. So we've got a weave here, and when head injury is part of the weave, these other things are more likely also. So I said that we'd focused a bit on young people in prison. And we looked at 100 young males in Parliament. Same as in adults, 80% had a history of significant head injury. Again, it being most often repeated, mild head injury, and the repeats continuing and persisting over a period averaging 4 years in these people. It's a long period of time given their youthfulness. Again, as in with the adults, fighting is most common. The mental health problems that we looked at, particularly anxiety and depression, but they also commented on anger and difficulty controlling their temper. We had indications that they had greater difficulty with self-regulation of their behaviour and controlling impulsive behaviour, including in prison. They were more likely to have carried out, have a record of prison infringements, breaking the rules in prison. Disability from head injury was less common in adult males. And there's an issue here of them being at a crossroads, because if in other respects they're similar to adult males, you could see that they might be on a path to more of them having this significant disability as they get older. And so an issue really of trying to get them to depart from that path. We know in the UK a third of prisoners in general recidivate within 12 months. We don't know yet if the extent to which head injury is an extra risk factor, making that more likely. Now, some of the people that we saw had brain injuries quite early in life, when they were small, and the effects of brain injury early in life may have some impact then, but might become more apparent in adolescence when there are complex demands associated with social judgment, and they have really difficulty dealing with these demands, and it has significant impact on them. They're more likely to be risk takers and rule breakers involved with the law. And the emotional and cognitive effects of head injury are hidden, which we referred to earlier on. So there's not awareness of the impact of head injury. Though we also know that as young people mature, a significant proportion stop being involved with the law. They kind of settle down, they stop being involved in the law, but we don't really know whether head injury makes this more difficult, and if this is another issue in their crossroads as they mature and settle down, and as their brain matures, of course, and perhaps the frontal areas exert greater control. So research workers gave some views. We had research workers who interviewed the young men, and they said that they noticed they didn't independently recognise they'd had a history of head injury from gang fighting. They hadn't considered head injury as part of their ongoing needs. And even if they'd lost consciousness, they didn't quite understand what impact that might have. And like the adults, the adult prisoners, they voiced needs to do with psychological services in prison and problems accessing these. So one issue really is potentially a role for education. Head injury, the people who are victims not realising that head injury might be significant, and not attending hospital, not getting access to information really. So we provided a single group session of about an hour to adult males in prison, and we assessed them before and after. They often had little awareness of the effects of head injury, and their knowledge improved across the section, and at a month it remained improved. The prisoner feedback was very good. They found this very useful. They shared it with other prisoners, and we've been expanding the and working more on the content of the session. We hope to be able to kind of roll this out across the prison service and Scotland in the near future. So what about support that you might be able to provide? You could make written information about head injury available. You could encourage attendance at head injury education group if that's available. You could refer them on if you're concerned about their welfare or behaviour. That might be to specialist brain injury services if you think it's a very severe issue. I can talk about that in the discussion, or could be to social work or the GP. Take account of the most likely persisting effects, to be forgetful, troubles planning and organisation. Encouraging use of a diary or notebook might help with that. And in terms of their impulsiveness and so on, it's an issue really of making them aware of when they're going to be at risk and making them aware of that and working out strategies for them to deal with that. And that has to be quite specific probably to the individual. But there are risks if they are using alcohol and drugs and need to be aware of the extra impact of that. Risk from getting further head injuries. Risks of not attending hospital, not being informed about the impact of the head injury and getting the head injury checked out. And you might want to facilitate information sharing with social work, other community support groups, or significant others that might support them if they give their consent. So just rounding off now, in Scotland, what we're doing more generally, well, there's been in addition of a question about head injury and police custody vulnerability risk assessment. If somebody goes into custody, they get an assessment by usually the police sergeant, and there's a question now about head injury, and in many custody centres, they've got access to forensic nurses, to observation room and so on that they can use if they're concerned about somebody having had a head injury recently and might be in this post-traumatic confusional state, for example. There's a question to be added to the NHS prison reception assessment, and we've been doing a lot of work developing staff training on screening, assessment and management of head injury with NHS Education Scotland, and these e-learning modules are due in Easter 2024. So NHS Education Scotland, if you're able to access their e-learning modules, you could access that. Social Work Scotland are looking at us doing a modification for them for social work staff, as is the Scottish Prison Service. And we're developing education media for prisoners with HMP Grampian. Now, you might think, well, I'm not quite sure where we would get other community support. You could go to Headway Scotland. There are a number of groups and branches throughout Scotland. There's a link there, or if you just Google it, it will come up. They also, Headway, have a brain injury identity card. It's designed to help somebody with brain injury be identified if they're in a difficult situation as having had a brain injury, and for whoever they're dealing with to take account of that. And they would have to apply for that and fill in a form and send that to Headway. But there's a link there which gives you more information about that. And Headway also have some guidance information for various support workers and professional groups. And there's also a link, the third link down there would take you to that. Basically, if you go to the Headway, the general Headway link, you'd be able to find all of these things. The Scottish Acquired Brain Injury Network is a clinical network, really, which provides information and guidance about brain injury, not specifically about brain injury in the justice system, but that link, they would take you to them, and they have kind of some general training about brain injury. It's not specifically about brain injury and justice. So that's it. Thanks very much.
Thanks so much, Tom. That was really interesting. I wonder if I'll start with a question that I had. I don't know, it's a little bit, my thoughts are all over the place, but I was thinking specifically about kind of how maybe schools and youth workers would do some of that screening of how would you then separate some of those things that are normal for adolescents, for young people, versus where there maybe would be a head injury. I'm thinking specifically about school exclusions, for example, when young people might be excluded because of their behavior, because of inability to control their anger, where they maybe have been involved also in fights and things, and where there might be a contributing factor of the head injury, though, likely a mild one, I would be guessing a lot of the times.
So, I think part of the issue with this weave is that some of the signs will be similar across different causes. But and so for them to screen for it in a very casual way is quite difficult to disentangle that, unless you do it in a more formal way. I don't know if they'd want to do that in that kind of setting. But there is an issue really in terms of simply identifying whether it's likely they've had a history of significant brain injury by talking to them about situations where they may have had a knock on the head. Now, quite often what you have to do is you have to prompt people without leading them. You do have to prompt them a bit because they don't recognize that getting thumped on the head in a fight is going to have resulted in a brain injury. So you have to ask them about that. You say, have you ever been in any fights? Have you ever had any knocks on the head in the fight? What was that like? What happened there? So it would be taking them through 2 or 3 scenarios. Have you ever, I know you're only 15, but have you ever been drinking alcohol, taking drugs and fallen over and bumped your head? What happened then? What was that like? And then trying to advise them about the risk of that, risk associated with that, at least giving them that information. So, I mean, that's the way I would begin to approach it if there was an issue about school exclusion. If they are seeing an educational psychologist or a clinical psychologist, they would be able to do an assessment to determine whether it's likely that they've got a history of brain damage that's contributing to this.
Okay, thank you. Yeah, I think definitely one to put in our materials for young people to even know that there can be effects, I think, because like you said, I think that's not really known maybe amongst youth workers and for young people. Does anybody else have any questions? They can be popped in the chat, or people can put their hands up to ask. Oh, there's one here from Nadine. Are there different patterns of offending or antisocial behavior depending on the age the head injury occurs?
So I think there's nothing very clear. There's no very clear separation with regard to that. The most characteristic is where people are going to act impulsively and aggressively. It's the most common thing. What you find is that across the board, there can be a tendency to be involved in all sorts of different types of crime. But the one that comes out most strongly is violent crime, and that is across the age span.
I wondered as well, sorry, I'm going to jump in with another question of, you'd said about some injuries obviously heal very quickly and some don't. Is there any ways that if youth workers are working with young people who they know have got a mild head injury, of apart from obviously avoiding further and any of the kind of drugs or alcohol or anything, is there any other ways that they can kind of support that recovery?
So there's 3 or 4 things that people are likely to benefit from. One is plenty of rest, avoiding alcohol and drugs for a period of time, abstaining, essentially, avoiding situations where there may be risk. And some of these situations may be just ordinary situations, like I always, ride my bike round to see my granny on a Saturday. I'll just walk round. Don't take risk. Your balance could have been affected. Your reaction time will be slower. You're not processing information. You're more irritable. So there's just greater risk that something's going to go wrong. So avoidance of risk during that period of time also. Plenty of sleep and rest.
Excellent. Is there any other questions? Does anybody else have any other questions? No. Excellent. In that case, I'll stop the recording here.